Antibiotic selection in the ICU is a critical decision, and Dr. Neeraj today will discuss on antibiotic selection in the ICU based on the CLSI and UCAST recommendations. So it's not just choosing the antibiotic that is marked as sensitive in the microbiology report, because critically patients fail therapy despite in vivo susceptibility, not because the lab is wrong, because bedside interpretation is incomplete. So let's translate CLSI and UCAST reports into clinical decision making, and this is a core competency anybody in critical care needs. So why ICU antibiotic selection is different? In the OPD, mild infections, lab reported susceptibility often predict success, but in the ICU, the bacterial burden is high. The drug distribution is altered, organ dysfunction changes the PK, pharmacokinetics, and biofilm and deep tissue infections exist. Augmented renal clearance is a reality, or renal failure alters the exposure. So the question is not, is the organism sensitive? That is not just enough to answer and select the antibiotic. But can this patient achieve effective exposure against this organism at this site by this chosen antibiotic? This is where CLSI and UCAST becomes clinically relevant. These are two bodies who have two philosophies. Both systems are categorized organisms into three groups: susceptible, intermediate, and resistant, based on the zone of inhibition. But they mean different things actually. The CLSI approach is based on, it assumes that standard drug dosing. So S means likely to success with the routine dose. I mean uncertain success with the routine dose. R means failure expected. This is a lab-centric report actually. Now coming to the UCAST, it's a different philosophy. The UCAST approach is a PK/PD centric. So sensitivity, standard exposure is sufficient. Intermediate, success is possible if exposure is increased, and R, failure even with increased exposure. That's how we should read. So UCAST redefined I as susceptible at increased exposure. This is not a warning. It is a specific instruction wherein, depending on the culture, when you hike the antibiotic dose, when there are no other patterns, it might still work out. So why this matters in the ICU? Critical patients frequently need higher doses of antibiotic. Extended infusions are often needed, or even continuous infusions are needed, or frequent infusions are needed. So, an UCAST intermediate drug is often perfectly usable in the ICU, provided you modify the dose of that drug and the administration. For example, Pseudomonas sensitive to piperacin tazobactam, CLSI use normally, that would be the recommendation. In UCAST, use prolonged infusion. Without PK optimization, treatment failure can happen in this context. Now let's look at the central role of MIC, or minimum inhibitory concentration. This matters more than sensitivity and resistant labels. Two drugs may have both sensitive S but may behave differently. Drug MIC and clinical reliability. For example, meropenem 0.25 as excellent, while cefepime 2 will be borderline. Both will be marked sensitive in the report. They are the same category but with different clinical performance. So lower MIC, greater probability of target attainment compared to the fellow drug which is susceptible. Now comes the most important crucial thing, PK/PD targets and ICU reality. Antibiotic success depends on the pharmacodynamic targets. For example, beta-lactam, time above the MIC is what determines. Aminoglycoside, peak above, peak is more than MIC. Fluoroquinolone, area under the curve more than MIC. Vancomycin, area under the curve more than MIC. So critically, patients often fail to reach these targets with the standard dosing. So UCAST encourages dose optimization in these patients. Now coming to the next, exposure optimization. So what UCAST reports as I, if you're using that drug and no other drug is available, use at a higher dose. Shorter interval of administration. Prolonged infusions or even continuous infusion should be attempted. Example, piperacin tazobactam. So instead of the standard dose of 4.5 gram 8th hourly bolus, use 4.5 gram every 6 hours with a 3 to 4 hour infusion rate. This improves the time above the MIC and likely to achieve more success actually. Next important thing is site of infection, which overrides the lab report. Susceptibility does not mean equal efficacy. Two drugs are susceptible does not mean equal efficacy, because the drug penetration differs. The site and challenge should be different. Lung has got epithelial lining fluid variability. Bone has got poor vascularity. CSF has got blood-brain barrier limiting. Abscess has got low pH, high inoculum, and endocarditis have biofilm effect. For example, ceftriaxone marks sensitive in ESBL bacteremia may fail in a pneumonia due to the inoculum effect. And in this context, carbapenem is preferred despite lab susceptibility. Now coming to the last but not the least, the inoculum effect. Some organisms appear susceptible at low bacterial density in the culture reports but fail at high density. This is typically seen in ESBL producers and AMC producers and in Staph aureus. So when the report comes as sensitive, example ceftriaxone sensitive does not mean it is safe in septic patient due to ESBL E. coli. Carbapenems are needed to overcome this. So UCAS directly identify and indirectly flags this through cautious breakpoints. So if you know the breakpoints which are reported, you can report that. Then there are special ICU situations like renal failure. Renal dysfunction does not mean avoiding potent drug. It means you should maintain exposure while adjusting the interval. Example, meropenem remains superior to ceftriaxone in ESBL even in CKD. Avoid underdosing, which means it will cause resistance. So people are always cautious when there is an associated renal failure. And then coming to augmented renal clearance, which are usually seen in septic patients who clears off the drug rapidly from the system. And standard doses may fail in this step. So if it is a UCAST I drug, become usable at a high dose of infusion for these patients. The routine dose may fail in these people. And one of the common infection, urinary infection, the higher urinary concentration allow the use of drugs otherwise unsuitable systematically. For example, nitrofuran and fosfomycin. These are increasingly secreted at higher concentrations in urine and may work despite systemic resistance because urinary concentration is far high. But they need a functioning kidney. Now coming to ICU drug selection hierarchy. When multiple drugs are termed as sensitive, which rarely happens but occasionally happens, choose them based on the lowest MIC. First should be the lowest MIC, then should be the best site penetration. The drug should be penetrant and enter the site. Stability against resistant enzyme is the third one, and safety in organ dysfunction. If these four are met, the next most critical one would be a PK optimization feasibility, wherein we may have to change the infusion rate, frequency, or even continuous infusion. An example is an ESBL E. coli bloodstream infection. The drug reports comes as ceftriaxone sensitive, piperacin tazobactam intermediate, and meropenem as sensitive. The best choice in this context is meropenem. Why? Because it's stable against ESBL. It is low MIC is likely, reliable in high inoculum, and PK optimization is feasible. But these are not possible in the other sensitive drug. So that's why we should choose in this a meropenem. Now, what is the practical bedside translation of a UCAST intermediate? Antibiotic ICU strategy for piperacin tazobactam, it will be extended infusion if it is intermediate. Cefepime, it should be high dose prolonged. Meropenem, 2 gram TID, prolonged infusion. If it is imipenem, continuous infusion. So these are the ways we will interpret I in a intermediate case. So I means it is not intermediate, it should treat intelligibly. Now there are common ICU pitfalls that we can avoid. Choosing a narrow drug purely based on sensitivity. Ignoring MIC. Bolus dosing in severe sepsis. Always give the bolus dosing, even if there is an organ failure. Use ceftriaxone for ESBL bacteria. Underdosing in CKD for fear of worsening CKD. Treating deep infections like UTI, where the inoculum effect is there, you need higher dose of drug. So this is how we will have to select. Now come to clinical integration. Before selecting an antibiotic, ask what is the organism, what is the MIC of that organism, where is the infection, what exposure is achievable with the antibiotic you are going to try, and is there inoculum effect. Now, does this host physiology alter the PK? If yes, then you should probably change the drug.